I think we can go ahead and get started, Andrew.
Okay. So I'm very excited to introduce Professor Madhav Marathe. He is a distinguished professor in biocomplexity and director of the Network Systems Science and Advanced Computing Division at the Biocomplexity Institute and Initiative, and a tenured professor of computer science at the University of Virginia. And he's published more than 350 articles in peer-reviewed journals, conferences, and workshops. He earned his BTech in computer science and engineering from IIT Madras, his PhD in computer science from the University of Albany at SUNY, and before joining UVA, he held positions at Virginia Tech and Los Alamos National Laboratory. So let's give him a very warm virtual welcome.
Thank you very much, Andrew and Milind and others. Pleasure to be here with you virtually. I hope I can meet you folks in person sometime, and you folks can visit UV as well in person. But for next few months, we still have to do this long distance thing. So I'm going to talk about the work the group has been doing for COVID. And before I start, I want to acknowledge the folks who funded us, as well as the group. This is by no means my work. In fact, there's a large group of us who are working together, and I'll say a little bit more. And as it is with any large group, my contribution is becoming epsilon, which is vanishingly becoming smaller and smaller by the day. So someday I think it'll reach zero.
I'm sure that is not the case, that you're giving them great leadership. Thank you.
No, thanks. But it's a pleasure to have such a good group of folks working. So some references for folks who might want to take a look at our work in the past. This a couple of tutorials we've done, one at KDD, one we did at AAAI. We probably can do one more sometime later. And there's a new expeditions grant that we recently got, and we have a web page for that as well, and that has many other resources. So let me start. So the talk is really about the journey of this group on how we have participated in the COVID-19 response. And I've tried to do it by stitching together some of the work we've done, which is somewhat theoretical, but also brought in the practical aspects, because I think that's what has distinguished this particular work. I could have either gone purely theory side or purely practice side, but I felt this mixture would tell a good story. And from our standpoint, we've been working on pandemic preparedness for a while with grants from various agencies. And we work with our DoD. We started tracking this sometime in December, but we were not sure what is going to happen. By February, it was getting to be clear that this might become something unusual. And we constituted a team around 13th of March, I remember, and started work on this. And we continue to work with our sponsors and others on a weekly basis, and I'll tell you a little bit more in the next few slides. But for folks who by now don't know why this was a pandemic, let me take 30 seconds and say a little bit about it. A pandemic usually happens when you have a novelty in the disease. So, humans had not seen this. In this particular, so zoonosis is the term people use. It's a jump from animals to humans. There's also silent spreaders in this particular disease that were quite prominent, and multiple modes. We're still figuring out that aspect. And finally, where it occurred. It occurred in a very dense part of the world, and also part of the world which had very strong connections to cities and places outside that small area, as opposed to say Ebola, where we worked with DoD, but it was largely contained in Western Africa, and the connectivity was not so strong, so that we could control it slightly better. The response has been quite amazing, right, in various forms. There's socio-political response. I never thought that US would have a lockdown of the kind we saw. It never even crossed. Even as late as March 10th, we were not sure this would happen. The amount of funds that have been released by various governments is large. The scientific response is huge. I mean, I think the number here is from slightly older. I just counted before coming on to this talk. It was about 80,000 preprint articles by now on COVID-19. It's just stunning what is happening. Avinash Dikshit at Princeton calls it another pandemic of sorts of publications in terms of its growth. And technological response has been quite amazing as well. With apps being developed, people able to work, remotely, classes being held. Again, never thought that you could run schools like that. Of course, at least big schools never thought that they would do it. So, what was our role? As I said, our group works on massively interacting systems, epidemics and pandemics being one, but we also look at other disasters. And we have been doing this work for 20 plus years now, since my time at Los Alamos. So in some ways, we had experience in working in this area. We participated in almost every large enough epidemic outbreak in the world since 2005 H5N1 scare that we had. Luckily, it didn't become a pandemic. The 2009 H1N1 outbreak, the 2014 Ebola outbreak, the Zika outbreak, among others. So we had basic tools and the team sort of ready. So we started constituting the team, and right now about 80 of us work together on this. And we support various agencies, DoD, CDC, our state, multiple units within state, the Department of Energy, Emergency Management, Department of Health, and we also support our university and local hospital systems. And this actually is very challenging in some ways from a standpoint of doing real practical applications, and to do science when the things are evolving so rapidly makes for a non-trivial challenging problem from a scientific perspective. And hopefully I'll be able to relate some of the challenges meaningfully here. So let me give you a little bit about basics. I think in this group by now everybody knows. 2 years back, maybe this was new, but maybe not anymore. Your group, Milind, already does a lot of work, but I thought for some folks who are new, they might find this of interest. So epidemiology has been studied for over 100 years now using compartmental mass action models. And this is early history for it, in 1900s, early 1900s. This was developed. It was also used by Ronald Ross for malaria eradication in some parts of the world. And its genesis can be traced back to the work of Bernoulli as early as 1700s, when he talked about understanding smallpox outbreaks and vaccinations. And the model is very simple. It basically is a coupled set of differential equations. And these equations tell you how folks from one state can go into another state. You don't have the notion of individual here. You have mass action models. So think of these as reactions effectively, whereas state S, state I, and state R, S being susceptible, I being infected, R being recovered. And you write a set of differential equations. You say the rate of change of density of the state in state S is directly proportional to the product of I and S states with a factor beta. And you similarly write one for I and one for recovery. And the number beta divided by gamma is called the basic reproductive number. And all of you must have heard about this. It's studied in a big way in epidemiology is important. And usually people would argue that when R naught is bigger than 1, you have uncontrolled outbreak, and the bigger it is, the harder it is to control. It's going through a rather rapid growth, basically. And this model, as I said, has been immensely successful. And to date, people use it. We use it. Many other groups use it at universities, and it provides very interesting insights. But it does have a few weaknesses, right? For one thing, this model does not account for any of the heterogeneity that exists in in the society. And so our work that began in early 2000 was based on the hypothesis that if you want to understand disease propagation, then we want to understand it as a propagation on a social contact network, because we feel that that captures the inherent heterogeneity in the population, both from the connectivity, structure of the network, as well as behavioral representations individuals might have, as well as the adaptations people might make as the disease evolves. And hopefully this representation would give us new insights into the contagion dynamic and lead to better response strategies. And hopefully we believe this is still true, and it's a matter of debate. I would not say that the matter has been completely settled. I think in general, there are models based on compartmental systems that would work very well for certain class of problems, while others would be better served by this class of models. Of course, the weakness of this class of models is that they require far more computation and data, and so sometimes which is hard to have. And we are not necessarily the first people to have maybe studied network models, although one of the early groups. I think people probably knew about network models early on, but as I said earlier, when people were studying such systems in 1950s, 60s, 70s, even 1980s, think about what you would do with a network model. Once you have a network of, say, 1,000 nodes, you cannot really do much in terms of solving anything meaningfully on this network. So while you might have a good representation theory that was not compatible with the computational resources one has, but now things have changed and you can do some massive computation. So I think that's why this has come around much more strongly in the last 15, 20 years. So let me explain you the model of networked epidemiology. It's a very simple model. And in the next two slides, you'll understand all the mathematics you need to understand to prove theorems about it. The theorems turn out to be very hard to prove. The model is extremely easy. And it's kept simple enough. You can, of course, add complications to it as we go along. So what's the model? Here I've shown a simple cartoon of a 7-node network. Think about these nodes as agents and edges as their interactions. Depending on the disease, edge might mean something else. If you have a sexually transmitted disease, for instance, edge might mean a different kind of contact. If you have a influenza-like disease or airborne transmission, the edge would just mean coming in physical proximity within certain distance for a certain period of time. So you'll assume that such a graph for now is given. And each node can be in one of the three states. Either it's a susceptible node, infected node, or recovered node. You can add more states to it too, and we'll talk about it later on. And in the model, you start, let's say, with one single infection, V0. Again, you can generalize it. And the labels on the edges tell you the probability of transmission. So the semantics are that if V0 is infected and V1 is not, then with probability half here, V0 can pass the infection to V1. And here probability of half is given on many of the other edges. And it turns out that if V0 wants to infect V1, V2, and V3, it independently tries to do this. So there are two forms of independence here. One, when you have multiple neighbors who are sick and trying to infect you, then you're infected if any one of the neighbors infects you. When you are trying to infect others, as in this model here, again, you toss the coin independently for each of the events, for each edge, and try to infect them independently. So this independence is important in this particular model. You have other models where this independence is not assumed. You can work with groups, but this is the easiest and simplest to work with. So that's the model we have. What do you get out of a model like this? If you start with the disease at node V0, then in step 1, it can possibly happen that V0 infects V1 and V2, that is shown in red. And let's say for this model, V0 recovers after one time unit, so it becomes green. V1 and V2 then try and infect V4, V5, and V6. So you can note that V1 and V2 are trying to infect V4 simultaneously, and one of them goes through. Let's say V1 was successful, V2 was not. V5 was not infected by V2, and V2 also infects V6. And the last step, V6 was able to infect V3, and then V3 recovers. So V3 did not get infected from V0, but got infected from V6 in this particular event. So time is shown from left to right, and the configurations are shown up there. And you can write down these configurations in a table as I've shown. So time 0, it's I followed by 6 S's, 6 of those nodes written in order, V0 to V6 in that order. and then they evolve. So for a computer scientist, this is not a very hard representation to imagine. We'll come to that. So one way to visualize the output of such a simulation is through a dendrogram. What is a dendrogram? It just tells you who infected whom. So in this case, V0 infected V1 and V2, V2 infected V4, and let's say not V6, it should be not V3, it should be V6, and then V6 should infect V3. So that's an error in my chart here. So that's how the infection should be shown. And this directed graph captures the spread of the disease and how it appeared in this particular network. We'll assume for simplicity that it's a tree. You can assume it's a DAG as well, because for instance, as we discussed, V4 could have been simultaneously infected by V1 and V2. You can choose to put an edge, but such events might be small enough that we can potentially thin down the network to work with a tree, which is easy to handle for practical purposes. So the dendrogram is really the outcome of one single stochastic run of such a system. And this is shown by an object that all of us studied well, and in your group studies this quite a bit. It's a Markov chain. So the center of this is the starting condition, and in this, a probability of 1/8 is put on all the edges that tell you how you can make it through from one configuration to another. So the object is actually not that hard in some ways. You have a network of 6 nodes and you get a Markov chain here. The problem is that the chain is exponentially larger than the representation itself. So if each node can have 3 states, then the chain can, and there are n nodes, then the size of the Markov chain is 3 to the n, and in general much bigger than that. So that's the problem. If the Markov chain was small, you could in fact come up with some interesting dynamic programming style algorithms to compute certain measures. So all the interesting questions are questions about the structure of this Markov chain. But the computational complexity is measured with respect to the graph that is given on the top. And that's the gap that one has in trying to understand the problem itself. So let me give you a couple of examples which are of problems that are computation in nature, and then I'll switch into the practical side of it and tell you how we go ahead and use this. So I've chosen a 3 or 4 different set of problems just to give you a sense of variations that come in. So let's think about the first problem, which is a forecasting problem. All of us have worked on it. I have worked on it. Millen, your group has worked on it as well. And the problem is actually stated very simply. Let's say the simplest model, you're given a graph with n vertices and n edges, and you're told that a single node is infected. And you've told that it's SIR dynamics, the one I showed you, and the node gets sick after one. If I infect a person X, or X infects Y, Y gets infected immediately after one time step and recovers after one time step after that. So the incubation infectious period is 1, and the transmission probability is PUV, and we can assume it's a single number P if you want. And let's say I'm interested in studying some aspects of it, such as compute the probability that at a given time T, that the number of infections are large enough in a particular subset, and subset could be all nodes. So it turns out this problem is actually, even this simple problem is very, very hard. Okay, it's a number P hard to compute, and not just to compute, but to compute approximately is also hard. Moreover, the hardness sets in very, very early. And the same holds for other parameters as well, such as computing the probability, the number of infections at peak value are a certain number. Okay, so the point being that it is not surprising in some ways that these problems turn out to be hard, but the fact that the hardness comes in so early, and in many cases it's even hard to approximate, should give you a sense of how hard the problem is from a theoretical standpoint. We have just finished this document, and I'm happy to send this. It has got real implications. What it says is, even if I have complete information about the system, and the model is as simple as the one I've shown, computationally, it is hard to get provable worst case bounds in this, right? Leave alone the fact that data is noisy, you don't know the network, you don't know the probability exactly, and so on and so forth. The second problem is one of inference, which again is studied quite a bit. where you want to look at what's happening in the system and try to infer some property of the system. I have taken one particular example here, which is this, where you're given a network again, and you're told that it has got the same kind of SIR dynamics I talked about. But now, by looking at the evolution of who is falling sick, you want to infer the transmission probability on edges. So it turns out, again, this problem is hard, but you can actually come up with a randomized polynomial time algorithm that estimates this probability within a factor of 1 plus epsilon, and it does so probabilistically with a probability greater than delta. So it's an alpha, epsilon delta approximation in some form. And it uses some very interesting properties of active learning to go ahead and do this estimation. The last theoretical problem I'll mention is an interesting one that we studied for the DoD, but is actually applicable in situations where you want to sequester a critical population. So the idea is this: you have folks, let's say, on the ship like Diamond Princess, but let's say military base, and you have a pandemic. You want to protect soldiers, and you want to break them into small groups, so that you want to minimize the chance of the critical workers falling sick. If you knew who is sick up front when they came to the base, then it's easy, right? You remove them and you're done. The problem is, most cases you don't know that. So we want to come up with this strategy to optimally break them into small groups with some understanding of the risk that they might initially have in terms of being infected, and we have not detected them. So think about them right now coming to the campus, for instance. The same question applies. So we studied this back for DoD, and it was a very interesting question. What we were able to show is that if you have some sense of the transmission probability, and you're told what your initial expected probability of being infected is, which is SI in this theorem, then, and you're told that there are K groups, think about them as rooms, think about the barracks quarters, think about them as unit basically. Then you want to partition your individuals into K groups so as to minimize the size of the expected number of infections finally that you get. And it turns out there's actually a very interesting result that is possible. First, it looks like for this particular problem, with all these assumptions I made, you can actually come up with a polynomial time algorithm that finds a way to partition the population so as to minimize the size of the outbreak, the number of people who fall sick. And it's based on a very interesting monotonicity lemma that is the following. It says, if you order the folks in increasing order of expected infection probability that they come up with, S1 to Sn, then there is an optimal solution that puts them in that order. So first few will be in first room, then the next few will be in the second room, and so on and so forth. So intuitively that makes sense, right? Of course, the hard part is deciding where to break the set. But once you can show that this ordering exists, then a dynamic programming provides you with a way to split them into sets of good size. And you can actually generalize this quite a bit when different rooms might have different probabilities of infections and so on and so forth. So I just wanted to tell you these theoretical results. The last one I'll touch on because of its recency is the vaccine problem.
So Madhav, just a quick
clarification
question on the last one.
This one, yeah.
You're talking about finding, minimizing the expected number of individuals infected. Would the problem be different? I guess I'm trying to understand if it is the case that this is some kind of more fatal disease or something like that. I'm just trying to figure out if there is some different formulation whereby there could be unfairness that comes about, where we say, okay, we're going to keep some people very healthy, and a few people who are sick, they can all stick together and they'll all make each other sick. But we'll keep the more healthy people healthy by segregating them.
So roughly speaking, this is happening here in the sense that the folks who have least infection probability to begin with, when you come in, let's say, so the way we were implementing this in practice is that you come into to a unit, we can ask you some questions. Do you have a big family? Do you have, history of disease? Is your family sort of move around a lot? Have you gone out quite a bit? Do you have young children who have been going to schools? And you use that to estimate this SI. The problem is there's no other way to do it, because if you know, you can take them out of the set anyways and keep them separate. So you use that, and the algorithm does intuitively end up doing what you're suggesting, which is great news, because it says take the folks with lowest infection probability and put them in together in one set, then the next set and the next set. Of course, in some ways you want to distribute it so that now that the lowest infection folks are in one set, you can make that set slightly larger, because the chance of any of them is infected is low, so that the overall spread probability is low in a certain sense in that group. So you try to sort of balance out that condition. That's why the break is not uniform across the set in size of equal partition. But that might be another constraint. You might say that I don't want to minimize the expected total number of individuals, but maybe some people have a higher priority, so I want to protect them much more than others. That's why I think that's where you're coming to, and that might very well, that's a weighted version basically, where you are trying to not minimize the expectation, but a weighted version of the expectation maybe. Does that help? Okay. So this problem was actually interesting, and there is a way to think about this even while implementing. As our students come back to the campus, to some extent, this SI can be thought of the risk of infection. And one could think of placing them in dorm. It's not straightforward to do. The implementation in dorm is non-trivial, but certainly when you have group quarters, this is something that I think is worth doing. And sort of story behind this is that when we were studying this for the critical workers, intuitively, the thought was that, if there's a pandemic outside and folks are living outside, then the best thing is to pull them into close quarters on a base, or, let's say they're working in hospitals. What we're saying is, if these numbers SIs are large, maybe that's not a good idea, because they're living in such close quarters that you might end up causing a larger outbreak among your critical workers than just leaving them alone where they are and asking them to stay healthy and close by. So I've not talked about that aspect, but that aspect comes in, that, intuitively just pulling them for any disease where you are not able to pick the person up by a test early on, this problem arises. So of course, COVID arises, influenza arises, because the tests for various reasons don't pick up the person right away. If that happened, then this problem would go away. And in some ways, this is what was playing out on Diamond Princess, where the rooms were already decided. People were already in their rooms. You could not change that aspect there. And you kept on getting people sicker and sicker as it went away. In some ways, you could have decided to quarantine them on the ship, but maybe redistribute them so that this event might not have happened, we think.
So there's one more question in the chat, but I don't know if you want to.
Yeah, please. No, absolutely. Sorry, I can't see the chat at the same time. So I will, let's pause here and take questions, and I'll try to do that every 10 minutes or so. So please go ahead. I can see the chat here.
So DJ Ursal, please go ahead and ask your question.
Yeah, please.
So Madhav, it's just a follow-up to what Milind said. I was just curious, like, assuming that we did segregate these people depending upon their levels into specific groups, right? But then are we just saying that we are just mitigating the spread, but then there's no going to be improvement in the immunity of that group? That group will keep on remaining at that level. So how do you kind of improve that level, was my question, if that was the case?
So we have not considered immunity in this particular problem. We have assumed that, you come up with initial expectation of being sick, but we don't know. And then everybody has a chance of falling sick. Now, this model can be modified where your initial chance of being infected is SI. Your chance of falling sick is a new number, QI. okay, because maybe you have taken a vaccine, maybe you are just healthy, and then the probability P would have to be modified per H probability, because it says if I was sick and you are healthy, and what is the chance that I can pass the sickness to you? It's conditioned on the fact that you are quite healthy. P would change, but basically by playing with the probability P UVs on each edge, you can capture that to some extent, and we can come up with a result in that case too. If the number of these probabilities are too many, then our result breaks down because of dynamic programming. If the number of distinct probability values is still a finite number, then we can still solve this optimally.
Got it.
If the number is large, then the trick we play depends on how wide it is. But if it's not too wide, you can essentially discretize the probability vector into small values. So between size of 1 plus epsilon, 1 plus epsilon squared, and then club it together, and that still allows you to capture the basic structure of the problem well enough. Right?
Thank you.
Yeah. So the last problem is vaccine allocation. This is something that everybody cares about right now. It's a very hard problem. Let me state the problem. Again, what I've tried to do is I've tried to keep the problems in their description very, very simple. And then you'll see the practical part come out later. And the idea was to try and do something which is provable. It turns out even these simple problems are really hard to deal with. So again, you're given a simple graph, SI dynamics with a period of 1 for infectious period and incubation period, transmission probabilities PUV, and you're given a budget on the vaccines. And your goal is to select K of these nodes to vaccinate so as to minimize the number of infections. This is almost the reverse or complement of the influence maximization problem that Milind and his group have studied a whole lot, I think. So, your student and you've done, I met Brian, I think so, when I visited USC, that, he was working on it. So first of all, this problem is hard. It turns out that you can actually come up with an approximation when the transmission probability is 1, which means, it's talking about reachability here. Because even with transmission probability 1, the problem continues to be hard, but you can at least get a provable approximation. We proved it back in 2005, and then David Kempe, who was your colleague, Milind, at USC, proved it as well. Turns out to be a interesting kind of bi-criteria cut. They call it balance cut. We call it a bi-criteria cut problem. So you want to do a cut that is not minimizing the cut size, but also trying to balance it out, how many nodes go on one side of the cut or the other. That's how the problem comes on to be. For the longest time, we could not do any provable result for P less than 1, which is the real interesting case. So recently, Anil and Arvind and a few others seem to have gotten a bi-criteria approximation, polylog approximation for some special cases. But then they're still writing it up. But it's taken us good 10 years to try and find a provable bound when P is less than 1. It's just a really hard problem to crack. So I leave it as a question for you all to think about. I have 2 open problems I want to state, and then we'll go into the practice part of it. One is, I've already stated, when P UV is less than 1, not easy to solve. And in this example that I talked about, we assume that the starting conditions are completely known, but this is not really true, right? We don't know where it has started. So that's a question that people would really like to study. The second variation that is interesting is when the infected person stays infected for a few days and recovers. Here it's just 1 day, and that makes it harder. And the part that is very relevant in today's case is the notion of leaky vaccines. You can combine antivirals too. So leaky vaccine means if I get vaccinated, I still have a chance of falling sick, and I can still transmit the disease. You can have leakiness in either direction. And many of the vaccines that we are going to get for COVID in the early part might have this property. We still are figuring out, but almost certainly one of these properties is likely to hold, that you might still fall sick, but much lower probability. And if you get sick, you can still transmit, but again, the probability might be much, much smaller. And doing this is non-trivial to work with. finally, our approximation algorithms were by and large useless in the sense that the notion of optimality has to be defined in terms of implementable strategies. And I think, Milind, when you did the needle sharing problems, you had a similar issue that you faced, because notion of optimality has to be reconciled with how can you identify such people, right, in the real world, because the graph is not given to you. So you need to look for demographic features of my set that my optimal set is producing and use that to vaccinate. And I'll say a little bit more. So for instance, we were able to do some machine learning and say that our sets correlate quite well with folks with high degree nodes, or now it's intuitive, but the fact that came out through this theoretical result was valuable. So now at least it's partially implementable, because I can ask somebody a survey question, get a sense for their degree, and then use that. And we showed the result is robust. We don't need to get accurate estimate of the degree, but a range of degree is still good enough. So those are very, very important questions in practical setting, where optimal allocation that we are used to in computer science has to be translated into an implementable and yet optimal algorithm, rather than purely optimal algorithm in this particular case. So here's a second set of questions. This is again something that is coming up in our work right now as we're working with our sponsors. We assume that vaccines are available right up front, but that's not the case. In fact, the vaccines are given to you as a schedule. It happens for flu, but it also it'll happen for COVID too. So you'll get maybe 1 million vaccines every few days, for a while. Very, very different problem. It's a Markov decision problem in a certain sense. You decide how much to give. You can also see whether your greedy strategy of distributing it right away or holding it back makes sense, because maybe you can know a little bit about the system, and that might allow you to do a slightly better distribution than otherwise, right? So this is something we faced during the H1N1 work, and we actually wrote a paper in PLOS Computational Biology on the vaccine schedule issue. There are many, many other variations. I'm happy to tell. I think that you can write at least 5 different PhD theses right now with vaccine allocation problems. And so if there are students who are listening, I'm happy to talk to you, and you can take on any of these problems. I bet that you can make a good thesis out of it. So let's move to the practical side of this. It's sort of flip the story around a little bit. So all the discussion I had thus far assumed that I had a network. No such network exists. I said, how do you analyze the dynamics? We assumed the dynamics were easy to analyze. It turns out to be very hard. How do you design interventions? Even harder. And how can you forecast this? Again, very, very hard, because the data itself is noisy, the ground truth is not known, it's time lagged, and so on and so forth. So all this good theory, which is already quite hard in the simplest case, becomes even more complicated from a practical standpoint because all of these challenges. So the way we've started working on this from a practical perspective is we decide we want to build a network, because no such social contact network exists for COVID. And I think, Milind, your group has now built similar networks too. We've been building such networks for a while. And what we do is we take data from various sources, from census, from activity surveys, phone records. Now we can get digital traces, and put it all together to build a social contact network for a given city or region. So we started doing it in modest form early on when we were in Los Alamos. By the time we left Virginia Tech, we could actually build out a representation for the entire globe this way. We had to redo some of the work because of our move. We've again built up a capacity to get all of US now. So we can do this on the US. And I would argue that the quality of networks we right now have is probably better than most of the networks because of the data structures and the data we have used to put this whole thing together. So the basic idea, and we have tutorials at HCI and AMAS on this before, with Samarth and others. And the idea about all this is that you build a representation of a city that is synthetic, but statistically represent the city quite accurately. And the well-defined term of what accurate means in this particular case, but we preserve this sense of similarity to the underlying city. So New York could look very different in our setting than Washington DC. Washington DC would look quite different than Seattle, and so on and so forth. So it captures the density, it captures the age structure. Those two things now many people capture, but we capture many other properties as well from this representation. Now there is no single best network as such, right? So as we get more and more data, we keep improving this population, and we have built now US, and as a part of our rapid grant for NSF, we will build a more coarser version of this, closer to what people have used in practice recently, and release it to the community. And we hope to build it out for the entire globe, basically using Landscan and WorldPop and other data sets that are available to do this. So the second step is to build these agent-based simulations on top. So this also is non-trivial, as we argued. The disease model turns out to be far more complicated than the 3-state model that I showed you in the real world. So you have multiple states of infections. There are asymptomatic versions. Once a person is sick, there's multiple states about how the person goes through the hospitalization phase, how sick the person can become, eventually die or recover. If you provide them, pharmaceuticals, then that changes your chances of falling sick and so on and so forth. So this particular automata that we have for COVID has about 15 states in it, and each such automata is associated with one person in the simulation. So that's what makes this challenging, and it's been quite interesting to do these simulations. So when we did it one at Los Alamos, and then after that at Virginia Tech, the last paper we wrote with our colleagues, we could simulate this for the entire US fairly fast. We could do on a big machine with around 700,000 processors, we could do one run in about 10 seconds. So very large agent-based systems were built out. We are starting to build that capability back. We can do now, again, city-scale simulations fairly easily. And we'll start publishing our work. Been busy with the studies themselves.
Madhav, there's a
yes.
couple of questions in
Yes.
there is a couple
Okay,
of questions
sure.
in the chat. Do
Absolutely.
we want to take a break and
yes,
answer
let's
those?
do that. Yeah. So let me take the questions up again. Thanks for reminding me. I have a question on how the states of agents are defined and the spread to different agents. Good. So Tawfiq, the question is, the agent has 2 or 3 different kinds of states. One is that their progression of disease within the person. And then in the models we also have behavioral states, whether they will take vaccine or not, when they take vaccine, whether they'll have adaptive behavior or not, whether they go to work or not, and so on and so forth. So 2 kinds of states. The information on disease progression is essentially stratified by age and nothing more. So this automata exists for each age group. There are 6 age groups in our simulation, and each age group has a slightly different probability value on these edges. But otherwise, the structure is identical. How do we get this structure? Well, this is it's to some extent, Tawfiq, is art, because people do basic measurements in epidemiological sciences and come up with these numbers. There are a lot of published papers now on COVID, and you use that to infer them to the best of your abilities. But I would argue that many of these numbers people would constantly change as time goes by. It is not a fixed value. Even in COVID, we have seen numbers for transmissibility go up very high initially, now to much lower numbers. And Arushi had a question, what sort of data do you need to create this? So that's a good question, Arushi. The tutorials are there. We have used about 40 different data sets to give you a sense. Census data, travel diaries, Landscan data, NAVTEC data for maps, building locations for schools, colleges, hospitals, households. We now have Microsoft building data, so almost every building can be mapped. We have data from digital traces from various sources that we bought and gotten that get you some sense of how people move around, but that has to be inferred for an individual person. For the globe, many other data sets are available. So the tutorial has that, Arushi, and I'm happy to leave the slides with Milind and Andrew, and you can, if you have further questions, we can take them on later.
Prof, a follow-on
Yes.
to that.
Yeah.
In terms of defining the states of the agents, are they static, or do you use, because I've seen some model where they use AI, maybe to input the data, and that changes the states of the agents in different, depending on what is happening, either supervised or not supervised, or do you just define a particular strategy for each state and it switches to those strategies as defined, or you allow it to be, to have a dynamic inputs?
So the person goes through 15 different states, this model, right? So the person's state is changing in time, but it's not like the automata structure changes in our simulations in time at all. So once we have it for COVID, we'll stick with this particular form. If you study flu, then it would be slightly different. So it's data driven in that the inference of this disease transmission model is done via data that is available, and it might change every so often as more data is available in terms of the severity of the disease or the incubation period or latency period, recovery time. But it is not like the structure will change completely after that, at least in our model. Okay, good. So let me, Andrew, how much time do I have? I think 15 minutes, 10 minutes, 10 minutes. Okay,
Yeah.
let's go through this faster now. I'll skip this. Let's go to intervention. And again, I've taken just one intervention because that's all that is relevant so far in COVID, which is social distancing. And just even this intervention turns out to be non-trivial. And I try to show this through a graphic because you'll see the richness, because you need to study when should you apply the intervention and how long. That's shown in the top left. Whom do you give and how do you, who is intervened with and how are they intervened with? When closing place, isolating, quarantining, sequestering, all of them are different. And the bottom one talks about pulsing, where you intervene, shut down some things for some period of time, open it up again, go back again. Pulsing is a relatively new form. Not that theoretically this was not known till Neil Ferguson's paper. Nobody even talked about it because they didn't think that public health authorities had the chance to do something where you close down the society for small periods and bring it back up again, in fact. So the fact that this was mentioned was a big deal, and the fact that we are in some ways even trying to do it for the first time in Western societies is an amazing statement to make. I don't think so. I would have ever predicted that this would even be considered seriously, but it's happening as we speak right now in Europe. France is starting to think of lockdown again. Italy is starting to lock down again. Spain again. So finally, we build workflows because all the things that I talked about are just pieces of the puzzle. You want to solve questions about forecasting, analysis, economic impact, individual risk, solving inverse problems. This is what the simulations do. So I'll give you one such workflow. That paper is going to appear in Nature Scientific Reports. And here we basically try to estimate the medical costs of the infection across the US. So all 50 states. And the interesting part was this particular pipeline basically builds the agent-based model for a 300 million node graph approximately. And it's initialized with the case count that we get for every county. So about 3,000 counties are pulled in. We are lucky to get access to HPC facilities at PSC. We've been getting at a continuous level. We've burned close to 2.5 million CPU hours now doing this. Almost every day we'll set up these simulations, produce these outcomes and take it back because it's just very hard to run such a large simulations on a smaller machine right now. That machine is about 20,000 cores on it. Our machine ourselves here is about 3,000 to 4,000 cores that we use on an uninterrupted basis. So, what can we calculate? You can calculate things like, the overall economic impact, and the paper has details, but it basically does it in a counterfactual manner. So it tells you the total cost if you were to do voluntary home isolation, when you do lockdown, when you have certain amount of compliance. And the results are intuitive, but the point is that there's a trade-off between opening up the society versus the health cost you pay. And this, mind you, this is not even secondary and tertiary cost in loss of business. This is purely the cost that you end up paying because of people dying. And this is it's a debate where how do you put economic amount on somebody's life. And this is so we have taken numbers people have put in the literature. I'm not saying that's the right or wrong number, but people have come up with such numbers. If somebody's sick for a long period of time versus somebody dies, at what age they die, they have come up with numbers that tell you how to cost it. And that's the cost that has been used here in this result. So we have been forecasting as well for our sponsors, and we provide this data to CDC every week. There are now about 30 different groups that are providing this data. We have been working with CDC from last 5 years when they started the flu challenge. So Ronnie at CMU is one of the fairly prominent groups. Los Alamos is a prominent group. Northeastern is a prominent group. And Nick Reich actually has done an amazing job in terms of setting up a group at UMass where all these forecasts go in. He combines them using a simple ensemble. And what I wanted to just tell you from this slide is that forecasting is really hard. And this particular paper that we wrote in PLOS CB talked about a few important reasons why forecasting is hard, even in the context of influenza. First is that different surveillance units give different values. Second is that there's a lot of instability, so you get a lot of backfill, as it's called. Sometimes you stop getting surveillance data completely after a while. And we haven't seen this for COVID, but flu, you certainly see different strains coming into play, and we'll start seeing that in COVID too very soon. It's a matter of time. So making this problem really hard. But nevertheless, I think you can actually come up with some interesting methods. In the interest of time, I'll skip this. But how well do they do? That's a good question. Initially, it was very hard to do a good job. But as more and more data has come in, things have become better. But even now, it's not straightforward. When you get a sharp rise in cases when people don't expect it, it's not straightforward to predict it. So what we have done is we have built an ensemble style system. It's just stacking, you can call it that, where you use statistical models, simple metapopulation models, neural network style models, and agent-based model all go into the models. About 9 of them go in, and then we use a Bayesian ensembling technique to do it. I would say we do reasonably well. Have we nailed it? Absolutely not. And one of the big ticket items that I would like to sort of pass on as a moral of the story is that these systems co-evolve. So, I don't think so one should expect the kind of forecasting that we are used to in physical systems, because forecasting becomes endogenous to the system. If I tell you that you're going to get a huge outbreak, people might change their behavior, and that change in behavior in turn changes the numbers. And you might argue either your forecast did very well, so people changed, or you might argue people did not do well, forecast did not do well. So it depends on how you see this. So I'll skip this part. We've been giving such forecasts to our campus as well. There we have a little bit more data. We actually built out, Melinda and Andrew, a very detailed representation of a campus. We've got data from the registrar. We have DOM data. And so we build out a synthetic UVA where we don't again track the students, but we have a very good sense for how these campus networks are organized. And hopefully we'll refine it a little bit more as time goes by using some RFID style data sets as well. So I'll quickly start closing my talk by showing you a few other things. We have built a dashboard. We call it the COVID-19 surveillance dashboard. I would say after the Johns Hopkins dashboard is probably one of the more popular ones in terms of providing day-to-day numbers. It was built approximately the same time as theirs was built. We built out another system with Stanford, Michael Bernstein's group, on collecting information on social distancing. That project has stalled a little bit, turned out to be much harder than we thought, but we still are going to put it out for people to use. So this is basically information on various social distancing measures counties were doing. Our hope was to do a crowdsourcing system and collect it for all the 3,100 counties. We got some, and you can see how the spread is, and you can make your own judgments of where the data comes from. This is a little old. We also have similar ones for hospital utilization and forecasting on beds and PPEs and such. We have only released that for the state of Virginia. We're very mindful about not putting out too much information right now because of fair amount of challenges that go with it. Let me just leave it at that in terms of discussion. So we have given this data to our sponsors. It just is non-trivial to deal with questions and challenges that are asked, because it's not a scientific problem anymore right now. It's tough. And all of you sure have faced this as well in your work. So let me summarize, and then we can take questions. Let me just say a couple of things before I summarize. What we are doing right now is every week we give 7 presentations and data products. We give it to, we do a briefing to the Department of Health. We do a briefing every second week to the governor's office. We do 2 briefings to DOD, and we participate in the CDC challenge. And then we also brief the local hospital systems and the local universities, JMU, VCU, UVA. And all the group is organized around this weekly activity, because you get the data, you update, you get new questions asked, and you produce these results back. So it's been very, very intense. And I think it will continue for another 6 months. But we have learned a lot, and doing science in real time is something that I feel is challenging, but it's also necessary to do the best science we can do in a certain sense. I also have learned that use of models has to go beyond prediction. There's a certain amount of desire by everyone to try and predict what's going to happen. And then, of course, predictions don't come out to be true, as it is in most social systems. But I think models can be used for many other questions: resource allocation, intervention analysis, just sense making and understanding and explaining. I think models are very useful. And finally, I think this is the topic that I'm very, very passionate about. I've written an article, hopefully, we'll see where it goes. But I'm calling this new sort of area socio-political epidemiology. So I'm saying epidemiology alone is not very useful to study, especially in pandemic-like situation. It's really the social, economic, and political dimensions that are actually at least as important as the disease itself. And we are seeing this played out across the world right now. The economics, the politics, and the societal response is as important. In misinformation campaigns, protests, fake news, leadership, and lack of it, coordinated activities across the globe, across the states in US. All of them have a part to play in what happens in the end in this. So let me close with just 2 pointers. One is this expeditions project that I encourage you to take a look at. Well, and we also got a project by NSF funded called the Virtual Organizations, and we call it Prepare. I will share the link later on. The idea is to bring together a community of researchers across the globe to try and better prepare for the next event, which we know is going to happen too. It's hopefully not anytime soon. And NSF would like us to almost build an organization around it, with the hope that maybe later on one could build a modeling unit of certain kind, slightly different than what the CDC were to do in a certain sense, but focusing on role of computation and data science, which I think is immensely important in the current situation. So with that, I'll stop, Andrew. Thank you very much for organizing this. Appreciate it.
Thank you. Thank you for joining. Do you have to drop off right away, or is there time for
No, I can take questions. Absolutely. Yes.
So until somebody raises their hand here, I have a quick one. So I guess you didn't talk much about calibration, although I think I saw it in one of your slides. How do you think about using kind of estimates from the literature versus running the model with different parameters and trying to match to what you observe?
Yeah, it's a very good question, very hard question, but let me give an answer. Initially, when we do forecasting, we do what we call it adaptive calibration. We use essentially look at all the input data for the last 7 months and try to match the curve and then project forward. For forecasting purposes, it seems to be a useful exercise too. When we are calibrating for counterfactuals, that level of calibration, while desirable, is very hard, and especially for agent-based model, it turns out to be almost impossible to deal with the number of parameters. So we have used something simpler in this case, where we have calibrated to obtain, the outbreak that we've seen the past few weeks, but not much beyond that, and then make an assumption before that, and calibrate to the certain disease parameters in some ways. When we did before, up until recently, whenever we worked, most of the time the calibrations for counterfactuals were to just calibrate to a particular outbreak size or particular R0, as people would call it. Now with this data available, you can imagine if you want to calibrate all the 3,100 counties and take it forward, it becomes really non-trivial. So we came close enough, but I would honestly accept the fact that we have failed right now to calibrate that precisely for daily data that is coming from every county and matching it for all the 3,100 counties precisely and taking the model forward. That seems to be non-trivial task.
Yeah, Madhav, thank you for an excellent presentation. And I really appreciate the last bullet you have here of socioeconomic, political dimensions, because clearly that it does impact things. And not taking these into account and making recommendations, policy recommendations, seems to be not as fruitful.
No, I think that's just central. So myself, Rita, and Simon have written this article called Sociopolitical Epidemiology that hopefully somebody will give us a chance to publish. Because I think it's important. On one hand, everybody, when I say, people seem to sort of know about it, but I don't think so epidemiologists study this in a unified manner yet.
Yeah. Prof, that my question is actually on that same one, just a follow-up, because doing a model is trying to simulate reality. And then sometimes looking at the system thinking wise, you still isolate because you are looking at your own field as the epidemic side. So how do you couple the other side in terms of the social, economic, and political model? Could we have some kind of sub-model that links up to that and modulate and say, what impact does it have? It could, I mean, to remove complexity and some other things and still be able to see the impact such a dimension will have on the prediction?
It's a very good question. In some level, it finally is somewhat art. I don't think so. We understand where the system. So at the end of the day, it's an open system. We are almost all models treat it as a closed system with some exogenous things coming in. Where do you cut this line is not straightforward, right? So for instance, if I want to study economic impact, which is our second paper now that we are writing up, how detailed should the economy be represented? We have the epidemic layer done quite well. We are now representing using a IO input-output model, all the sectors in the US, and coupling these two models together. But you could take the economic sector and even further refine it by looking at agent-based models like Bob Axtell, my colleague at GMU, does, where he looks at every single agent, every single industry, and then playing it out. Now, I do not know where the line should be drawn easily. One takes up standard ways mathematicians would have studied and looks at, results where you would take one representation versus a coarser representation and looks at it from a sensitivity analysis standpoint or uncertainty quantification style standpoint. But otherwise, at least I do not know whether there's a principled way to do this. This notion of open system remains, as it in many cases. But your point is a very good point, Tawfiq. I think it's a problem worth studying if somebody can come with a very principled way to do this.
Hi, Madhav. Really interesting talk. And one thing that I'm curious about is when you talk about translating these strategies that for intervention that make use of the kind of full knowledge of the network structure, right, into the setting where, of course, we don't really know anything about what the network looks looks like. And of course, this is something that we've thought about for influence maximization problems, but here you're doing it on this much larger scale, right? It's not this like single population. You're talking about cities, states, nations, and so I guess I'm wondering, like, how far do you think we can get with this? Like what's when we talk about using things like characteristics of individuals that you can survey them for, how close do you think that gets us in the end to knowing the full network?
Right. So I think, Brian, it's a very good question. I think that one has ability to get more information to try and do this implementable strategy. So right now, for instance, the DoD and CDC are basically interested in very simple strategy, the age-based stratification, or they are looking for critical workers. There are only two strategies that are being played out, partly because it's hard to come up with this implementable strategy. One, partly the big issue, even if I come up with it, is a sense of fairness, which actually pervades it. So from a fairness and AI standpoint this is actually a really interesting question. So we're starting to work with one of the folks in the law school here, because I might come with a strategy that is even implementable, but it might not be viewed fair in some forms. That seems to be a driving force in some cases here. But going back, let's forget the fairness part. If you want to just understand this, at least our results are suggesting that 5 or 6 basic variables like age, household size, and I'm calling it your propensity to meet a lot of people, seem to capture the implementation aspect very well. So we came up with this idea. Maybe you might have sent you this paper. I think this is very interesting. So we come with the notion of vulnerability of a node or risk of a node, which is really the risk one gets by not just structural properties of network, but looking at structure and the dynamics as well as the disease properties. And then you correlate the disease score with these variables, and you find these 3 variables provide much of the information that you need, say 70-80% of it. And then the rest, there's just so many other questions to worry about that this matters. And we are able to compare this with CDC flu strategy in the past when we did for flu, and it performed well. Actually beat it by about 25%. Basically, we said, we'll ask question to somebody coming in. Do you, how big your family is, and how much do you move around? And if assuming the vaccines are not available to everyone, this is how I would do it. There's another issue, of course, Brian, for right now, which is about vaccine sentiment and refusal. So, simplest strategy, which is age stratified or based on critical workers, might be what people end up using, because these practical consideration of fairness and hesitancy might be so strong that everything else might not matter too much in the practice.
Thank you. Yeah, no, that's really interesting, both the practical features, then hopefully encouraging that we can summarize a lot of the algorithms.
Right. So I don't want to sound like Cambridge Analytica, that 5 features, but it does seem like few features, at least in the model that we built, seem to be a fairly good representation.
So maybe we'll wrap up there. Thank you very much for joining us. Super interesting talk, and thanks for sticking around to take questions.
Thank you very much, Andrew, Milind. Brian, good to see you. I met you at USC. Good to see you. It looks like you've joined the group. I'm really thrilled, Milind and Andrew, that I could join you folks. Hopefully folks will come here and visit us sometime, and hopefully we can continue the collaboration. So thank you again.
Yeah, thank you so much.
Yeah, take care. Bye.
Bye.